All right. Good evening, everybody. Thank you for attending the webinar. I think I chew off a bit more than we're going to be able to handle today. In preparing this talk, I see that there was a lot to cover. So we'll definitely touch on PCOS, insulin resistance, the prediabetes, and then if we got time, we'll do a few cases with diabetes as well. So as usual, these are my disclaimers. And so let's start by trying to look at where type 2 diabetes fits in terms of the physiology of the case. So if you look at the interactions of risk factors for prediabetes and type 2 diabetes, they're similar. Now, obviously, that's stating the obvious. But if you look at what we know of prediabetes, we've mainly concentrated on beta cell failure. Now, what accounts for beta cell failure? So we have a decrease in beta cell function, and that can be directly linked to genetics and then the fetal environment that that individual was born in. We also know that hyperglycemia begets hyperglycemia. In other words, once you got hyperglycemia, it in itself causes destruction of beta cells. And then we know an increase in fat and triglycerides also destroys beta cells. Now, genetics behind insulin resistance is based on ethnicity. You'll see that some people are more at risk of insulin resistance than others. And we see this classically from my gene pool, so Indians from the subcontinent, people from the Mediterranean area, Lithuanian Jews, the Lebanese. So there's certain, and then we see it in the islanders. So whichever island you're looking at, whether it's Caribita or Mauritius, the genes for insulin resistance are quite strong. And very interesting story behind that. If we got time, we can touch on that later. But there's a lot of environmental factors that play in as well. So maternal hyperglycemia definitely gets passed on in terms of cardiovascular risk to the child, and then maternal or fetal undernutrition plays an important role as well. So both extremes sets the environment up for that particular adult to then later go on and put on weight. So insulin resistance has a very strong genetic predisposition, and if one goes back from an evolutionary perspective, it's understandable because for most of mankind's life, and I've covered this before, food was a scarcity. And so there was no spas around the corner, and so your only store of energy would be fat or muscle. There were no fridges, there were no grains, we were nomadic. And so people who developed insulin resistance would be in a position to store more energy and thereby survive a longer winter. And so one of my talks recently, I've just given a talk to dietitians, and we spoke about an obese or an overweight child has an 84% chance of becoming an overweight adult. So therein itself is another factor. And then, of course, we've all become a lot more inactive now. I mean, I've given up working at Bera after 30 years 2 months ago, and now mainly in private practice. And my steps have dramatically gone down from doing over 10,000 steps at Bera a day to now I'm set to say just around 2,000. So obviously that needs to be made up at the rest of your day in terms of leisure time and making sure we're active. So all of this feeds into what we're going to discuss today. So let's start with insulin resistance. We're going to touch on the causes of it, some of the clinical features, the lab tests, a lot of controversies around that, consequences of insulin resistance, and then how may we go about treating it. So we started off by saying that there's a very strong genetic predilection for insulin resistance. Now, remember, 100,000 years ago, if an individual was insulin resistant, going through 1 or 2 or 5 long winters, the person who's insulin resistant is more likely to survive and therefore pass the genes on to the new generation. Whereas somebody who could not store their energy will more than likely pass on and not be in a position to pass the stool on. Sorry, so I'm told the slides are not moving on. My good wife just came and told me. So are you guys, could you see the slides moving? Anybody?
No, Dr. Barner.
Thanks, Kim. I'm going to stop sharing and starting this bloody thing again, okay? Stop sharing. So on my side, it's showing that, see, I'm stopping the sharing. There we go. All right. Share. Good. And now, can you guys see it?
Yes, that's much better.
So did you guys see this screen before?
No.
Shame. Okay, so all of you guys just were kind enough not to tell me. Okay, cool. So let's just quickly touch on this because this is important, right? So from a genetic predisposition, I'm going to try and get my laser pointer back on. And so if you look to the top left, ethnicity, I mentioned there's certain race groups that are going to be at a higher risk of developing insulin resistance, and genes play an important role. And I spoke to you guys about, from an evolutionary perspective, why that becomes important. If you go to the right, fetal environment, very important. So if mom has prediabetes or diabetes, that's been shown to influence the child's future risk of PCOS, prediabetes and diabetes, and especially cardiovascular or cardiometabolic conditions. Now, it's interesting that at Barra, Shane Norris has done the birth to 10, which became the birth to 20, and now the cohort's been going on for over 30 years. They've shown that moms that have diabetes, their children have a higher risk of cardiovascular disease when they grow up. And this is once you follow them on for a whole generation. So if you look at the second factor in terms of maternal and fetal undernutrition, why would that be the case? Remember that if you basically have been underfed, for whatever reason, from a nutrient perspective, from a calorie perspective, that particular child, the body would basically map out the size of the heart, the pancreas, the liver, and when that individual get exposed to a lot more calories at a later stage in life, they're going to hold on to it because they're insulin resistant, and that's where the mismatch happens. And that's when you're going to start having problems with insulin resistance and beta cells. So that then feeds into the possibility of being overweight, and we become less active. The foods are a lot more calorie dense. And then genetically, with environmental factors, and our children are becoming a lot more inactive now than previously. All of that feeds into the insulin resistance presenting earlier. And with each generation, it comes at least a decade earlier. And then we've got beta cell dysfunction, which can be genetically determined. It can be influenced by the environment, where hyperglycemia is going to damage the beta cell, and so is high triglycerides. And all of this will lead to prediabetes. Now, typically, the gap between being insulin resistant and prediabetes can be anything from 10 to 20 years. And from prediabetes to type 2 diabetes can be 5 years. So, of course, if we wait for type 2 diabetes, we're already starting too late. And I'll show you that a bit later graphically. So we're going to touch on the causes of insulin resistance, some clinical features that you can use for some of you that are on the webinar tonight that don't have access to blood tests, lab tests, consequences, and then of course, we'll touch on treatment. So some of the causes of insulin resistance. So we spoke about the strong genetic predilection for it. And remember, this is the gene that survived millions and millions of years of basically food that was hard to get by. So this was a genetic advantage, which in the last 100 years has come back and bitten us. In terms of lifestyle, I've touched on this. Like myself, a lot of us are becoming more sedentary because of the kind of work we do. So we've moved from a labor-intensive society to using more of our intellectual prowess. And so we're sitting behind desks, offices, banks, and we're not getting our 7,000 to 10,000 steps a day. Now, there are certain syndromes that make it more likely for people to be insulin resistant. So there are certain conditions called the lipodystrophies, where these individuals actually don't have any fat stores and they are highly insulin resistant. They're also very hairy, and these are genetic syndromes. We see a pseudo form of lipodystrophy in patients that were on treatment for HIV, especially with the first and second generation ARVs. We also see this in acromegaly. So in acromegaly, where we've got excess growth hormone, the risk of insulin resistance, type 2 diabetes is very high. Cushing's, which is a condition with excess cortisol. So whether the cortisol is being made endogenously by a gland gone wrong, or whether we take steroids from outside, as in prednisone or hydrocort or Medrol, all of these feed into the insulin resistance. So what are some of the clinical features? So the first is a dorsocervical hump. In the past, it used to be called the buffalo hump, and it was typically described in Cushing's, but we see this in insulin resistance as well. Just bear with me. I'm trying to get this cursor without the screen changing. And so lost my laser, went off. Okay. And just go back and we'll guide you through where to look on the side. So on the top, the dorsocervical hump, if you look at the pictures on the bottom, some patients tell me, oh, they thought they had this because their posture was wrong or they're busy working on computers all day. No. So the gap between your finger as a clinician and that vertebra that you feel at the base of the neck should be 1 to 2 millimeters, no matter how big you are. And once you start developing a bit of a cushion there, that deposition is taking place because of insulin resistance. Now, on the top right-hand corner, I've shown you a very extreme version of acanthosis nigricans, and you'll see this dark, velvety discoloration on the nape of a neck. And just yesterday, I had a patient who was very light-skinned, and there, all you can do is you can feel the velvety aspect of the skin, where the texture is completely different. So it can be as gross as this, or it can be as subtle as just velvety skin. You will find this sometimes under the arms in females, sometimes under the breast, in the groin area, on the folds, and that's a classic sign of insulin resistance. And then you can have skin tags as well. So skin tags that were not there, and as you get older, you'll see the development of these. Now, those are all clinical features of insulin resistance. And unfortunately, we miss this in our practices because this you can pick up 15, 20 years before somebody is going to develop type 2 diabetes. So the lab tests, your classic lab test is to do a clamp test, where you put up a drip and you put in X amount of insulin to match X amount of glucose that's been infused, and you're trying to maintain a certain sugar level. So you clamp the glucose and the insulin, and then you work out how much insulin the person used to maintain a sugar at a certain level. It is very laborious, tedious, costly, and I think you'll find very few people volunteer for the test. And so I've been doing clinical trials for pharmaceutical companies for well over 20 years, and over the 58 odd clinical trials we've done, about 50 of them were in the field of diabetes. In every one of them, from back 20 years ago, we've always done the HOMA index. So it's a mathematical equation. It takes the glucose at the time, and preferably fasting. So fasting glucose against fasting insulin, and then it gets put into an equation and you get the HOMA index. And typically I aim for levels of around 1. Anything above 2 is showing you insulin resistance. Now, what's worrying is the reference ranges we all use from our laboratories. So typically you'll find on the Lancet lab, they'll tell you the upper limit is 10. So this is a challenge for all of you guys out there. Open up your Guyton textbooks. That's the physiology textbook. And if any of you can show me that a level above 5 in a fasting state is normal in any physiology textbook, then I'm willing to change my thoughts on this. So definitely we should be looking for levels between 3 and 5. Now, what are the consequences if we leave insulin resistance? Well, you can just remain in an insulin resistant state. And I'll show you that graphically in a little bit as well. So 85% of people that are overweight and obese will be insulin resistant. Sorry, if you took 100 people that are obese, 85 of them will be insulin resistant and eventually burn the beta cells out and become diabetic. There's the 15% of people that will continue being insulin resistant. They're able to pump out as much insulin as needed, never turn diabetic, but can still have some of the consequences thereof, which is mainly obesity. Then you can get polycystic ovarian syndrome. So this is important, and we're going to touch on that a bit later as well. So about a third of females between the ages of 30 and 18 and 35 may be at risk or have polycystic ovarian syndrome. We know certain subgroup of population are more at risk. So people from the subcontinent, Pakistan, Bangladesh, India. We know people around the Mediterranean area, Portuguese, Spanish people, speaking people, higher risk in the Jewish population, and certainly in a lot of the islands. The consequences of insulin resistance is obesity, and for years we've been blaming our patients to say, because you're obese, you insulin resistant. I've got the good fortune of having been in practice for a long time, and what happens is you see an adult who's got the means, who come and see you and they've got diabetes, and part of the test, when I do the HOMA index, I explain to them that, listen, you've been insulin resistant for a long time, and that's the cause of your diabetes. And then I tell them, oh, you know, this dark mark on your neck. And they say, oh, wow, you know what? My son or my daughter's got that. Just 1 second, my boys left the door open and I need to close it. And so, apologies about that. And so, I've had the good fortune for the last 20 odd years to then treat a generation before we would normally see them clinically. And sure enough, you will see these people in their teens sitting highly insulin resistant, and they're thin. They haven't put on the weight still. And so now in my practice, I see up to the 3rd generation, and it's easy to see because you'll see a mom coming with their daughter. Now the mom has moved on in life and has put on some weight, and she's sitting at 70, 80 kilos. You'll see the daughter sitting at 45, 50 kilos. And I'm trying to tell them that this hormone, this insulin resistant state is going to cause them to put on weight. And they're surprised. They're thinking, what the hell is this doctor talking about? And then I go to the mom and I said, what did you weigh when you were her age? And none of the kids actually believe that their mom used to be thin. And so I believe is that in most cases, the insulin resistance comes first, and insulin is a growth factor, and it's the one that grows the patient, and that's when they become obese. So it's not the other way around where we used to blame our patients, say, lose your weight and the insulin levels will come down. Yes, that may be the case, but you're not getting rid of the underlying state. In terms of fatty liver, so in my mind, I look at fatty liver and I look at two causes. One is insulin resistance, and the other issue is the problem with the gut microbiome. And remember, I mean, insulin resistance has been with us for a while, but this thing about fatty liver has become big in the last decade, 2 decades. And so we were doing liver function tests on all patients. We were doing liver ultrasounds for the last 30, 40, 50 years. We've never seen this much fatty liver. So there must be something other than insulin resistance that's feeding into this frenzy as well. And I believe the gut microbiome plays a very important role. And then, of course, one of the big consequences is prediabetes and then type 2 diabetes. And we must remember that in terms of the metabolic syndrome, prior to obesity or central obesity becoming the central component, for about a decade, it was insulin resistance, prediabetes, or diabetes that was a central component. And so now it's central obesity and either prediabetes or diabetes with hypertension or with dyslipidemia. And so insulin resistance plays a very important role there as well. I touched on the cardiovascular consequences of it. And then, to me, insulin resistance also spells out low-grade inflammation, which underpins all cardiometabolic conditions. So how will we go about treating these patients? So before I go through the products, it's very important for us to get our clients and incentivize them in one way or the other to change their lifestyles. So because we've all become more sedentary, it becomes difficult to get to our 10,000 steps a day. And so that's the difference between what was happening 200 years ago and now. And so we need to find the time. And my first goal for every patient is to say, just get to 10,000 steps a day. The speed doesn't matter, whether you do boxing or CrossFit or just walking. My first aim is to slowly build the patient up to getting to 10,000 steps a day. And then you can talk about intensity and the type of training and strength and cardiovascular and a mixture of those two. And so that's very important. And then, of course, once you've got insulin resistance, you know your poison is carbs. It is not protein. It is not fat. As long as you're not frying those, for me, the major issue is then it's carbs, because it's carbs that stimulate the insulin release at the level of the pancreas. And so and this might seem obvious now, but for the latter part of the last 3-4 decades, we've been talking about calories. So whilst calories is important, I think it comes secondary to actually carbohydrates. And so with those two coupled, let's look at some of the natural products that are available. So chromium, around 200 micrograms. We must be careful because I get patients every now and then being flooded with a lot more chromium on board, and the type of chromium you use is important. And so once you start using too much chromium, the risk of beta cell hyperplasia and neoplasms become higher. And so chromium helps the functioning of the beta cell, especially at the receptor level. And so chromium is important. What about guar gum? That's the Indian name for a fiber. The Western name is called manna. And basically, like acarbose, guar gum, once it's ingested, basically takes on fluid and just increases in volume. And there's a massive increase in volume. So what that does is it causes distension of the stomach. So the client will eat a bit less because they'll feel satiated. And of course, what happens is once the food gets into the stomach, you normally, after churning it, will release it, and instead of causing a peak in glucose, it extends the glucose excursion. And so the slow release of glucose will cause less of a peak. What about HCA? So we've been using this from about 2003. It was Dr. Oz on Oprah that popularized this one. It comes from West African mango extract, and very important in terms of decreasing the excursion of glucose being released. So it's a slow release from the stomach, and typically you need 1 or 2 capsules before a meal, and you do that 3 times a day. Bitter melon, bitter gourd, Karela, that's the Indian term. Basically, the extracts of this particular fruit also helps with insulin resistance, and there's many small studies showing that. Cinnamon, so it's no wonder when you go to India on holiday, you'll see most of the desserts will be laced with cinnamon. So cinnamon didn't come as a flavorant. Cinnamon was always there to try and balance the ill effects of glucose in dessert. And so one needs about 3 grams of cinnamon. Now, the problem with 3 grams of cinnamon is you're going to improve your insulin resistance and end up with gastritis. So it's always important to try and use a concentrate, so you end up using less than 3 grams, and you just got the potency increases because you're just taking out the active ingredients. D-chiroinositol has become big in the last decade, very important for the insulin receptor cell on the beta cell, especially with the second messenger pathway, and lots of products with D-chiroinositol. Berberine, the new kid on the block, lots of YouTube showing should we be using berberine instead of glucophage. I would argue no. Berberine is very good. It's an important player in improving patients with insulin resistance. Once you got a patient with the fasting insulin above 10, that HOMA index above 2.7, 2.8, it's not going to be strong enough. And so if one had to weight up in prediabetes against metformin, I think it will always lose. It's got lots of benefits, but remember, French lilac, which is the basis of metformin. I don't know if you guys know, metformin comes from the Celtic people. They used to use a plant called goat rue extract. You can Google it, also better known as French lilac. And that's been shown to basically help people with diabetes, and it's been used for over 2,000 years. And so its origins are natural, and there's very few molecules on this planet under $70 that can decrease the risk of insulin resistance, PCOS, prediabetes, diabetes, decrease your risk of arrhythmias, cancers, Alzheimer's, and stroke. So berberine, I think, is a player, but I'm never into the game of saying which product is better. One needs to understand the role of each, and each has a role to play. Alpha lipoic acid also can be used in insulin resistance. It is weak. It's very well advertised, but when it comes to potency, it works, but it's weak. Gymneva sylvestre. When I first helped Solal formulate a natural combination product for insulin resistance, the first generation product had Gymneva sylvestre. And what we found is that in some clients, the insulin levels actually went up. And so from that perspective, that wasn't a good idea. So although the glucose came down, it was doing it in some individuals at the expense of driving the beta cells. So in my mind, that wasn't any different to Dimicron or Emerald. It was working like an SU. And a sulfonylurea is exactly what you don't want in the long term if you want to save that beta cell. Very important to get your multivitamins and especially your B's and magnesium on board because they play a role as second messengers and cofactors. What are some of the pharmacological products for insulin resistance? So these are all highly off-label. There's no product currently registered for use in terms of insulin resistance. But what works? So metformin works because metformin basically doesn't drop glucose level. It improves the functioning of what happens to insulin at a cellular level. So it teaches the liver, the muscles, and the fat cells to take up glucose because they are resistant to insulin, and so they're not reading the insulin message, and so they don't take up the glucose, and the glucose levels are higher in blood. Whereas once you overcome the resistance, these tissues start listening to the signal, and metformin improves that. The SGLT2 inhibitors, this is a set of drugs that basically causes the kidneys to pee out the sugar. So for the first time, we've got a product that gets the devil out of the room rather than just shifting the deck chairs on the Titanic. The GLP-1 receptor agonists, so these are the drugs par excellence for type 2 diabetes, and the way they work is they get the beta cells to work, but sensing the release and the use of this hormone is based on the amount of glucose that is there. So it has a brain in the sense that when the glucose level starts dropping, it's got its own internal sensor and it will stop working. That's why it doesn't cause hypoglycemia. But it works at many other levels in the brain, in the liver, alpha cells, in the foregut, in the intestines, and the signals going out to the fat cells. So works on insulin resistance as well. The TZDs that lost their flavor because of the scare of rosiglitazone and cardiac failure and cardiac deaths. However, there are many other TZDs that have not shown cardiovascular increase risk. So pioglitazone still on the market and also works on the PPAR agonist and very good for insulin resistance. And then acarbose is like that second agent on the natural product side, guar gum. So I must emphasize that these are highly off-label. There's no drug currently registered for insulin resistance. So this is that graphic representation that I was talking to you guys earlier. So I've lost this laser printer since I've gone, not laser printer, what am I saying? The laser pointer, since I've restarted. So if you look to your left, just look at the two big, deep red bars. Now we're going to go above it. To the left, on the top, you see prediabetes. And it says impaired fasting glucose and impaired glucose tolerance. So that is glucose levels. Now, glucose is very dependent on insulin. And that's what we've seen on the bottom. And so what happens is with insulin resistance, what happens is slowly, as the beta cells becomes dysfunctional, we find that the glucose levels start going up. So you find in, let's call the color, I don't know what, a maroon. You find fasting glucose in the maroon going up. And then the top line, the blue one, is looking at what happens 2 hours after a meal. And so you can see that one goes up even higher. Now, why is it doing so? So if you look on the bottom, what happens is as one has insulin resistance, and with time, either because of a sedentary lifestyle or we're eating badly or our beta cells are just bad genetically speaking, initially we were able to push up the insulin levels in yellow. But basically 85% of people who are insulin resistant will eventually fail, and you'll start seeing that yellow line going down. And as you decrease your insulin production, you can see on top in the maroon and in the blue line, the sugar levels going up. That 15% of the people I told you that can just be insulin resistant and never develop diabetes is that line in gray, where some people will just go on and never develop diabetes. They will be obese, but they won't develop type 2 diabetes. Now, what's interesting is that we've always known that once you become diabetic, and that's the red line going vertically on clinical diagnosis, at that point is where you start calling somebody diabetic. The sugar level goes above 7 in a fasting state. You start developing microvascular complications when that HbA1c is sitting 7 or more. You'll notice that the line below shows macrovascular complication. That starts long before the diagnosis of type 2 diabetes. And that's why we've always known from the UK PDS study, which was a 20-year study, the biggest study ever done in patients with type 2 diabetes, that on presentation of type 2 diabetes, quite a few patients will already have underlying cardiovascular disease. So there's something happening. We either have to change how we diagnose diabetes, and it needs to drop from 7 to something lower, or we need to admit that besides glucose, it might be insulin that is directly affecting it. So one of those two needs to change. We can't carry on with our current status quo. Now, why did I clump insulin resistance, PCOS, prediabetes, and diabetes together? And I'll take it one step further, and I'm not going to discuss it because it's a rare condition. 17-hydroxyprogesterone levels get elevated in a condition called adult onset congenital adrenal hyperplasia. To me, these are all one basic pathology. So if you had to draw a line, basically they all have the underlying theme is insulin resistance, and basically where you're pegging it on the line, you will see these different conditions. So PCOS, called polycystic ovarian syndrome, just incidentally, this was my first case study in third year when you had to do electives. I went and did mine at a gynae, and those days they used to call it the Stein-Liebenthal condition syndrome. And somehow I developed an interest in it, and I did my case study on this. So back then, the belief was that the pathology was in the ovaries, and these individuals were making many cysts, and that's what caused infertility. Over the years, the definitions have changed, and now they look at something called the Rotterdam criteria, and basically it's three things that are important. Irregular cycles, which can eventually become amenorrhea, where the client is not bleeding. Features of hyperandrogenism, so these can be clinical or lab, and then you can demonstrate using an ultrasound cysts on the ovaries, and these will be multiple arrested follicles. Now, some of you may or may not know, you only need 2 out of these 3. So you don't have to have the cysts to call somebody polycystic ovarian syndrome. And so, because that may come a bit later. And so it's interesting that over the years, how that has evolved, where initially the gynae said you have to have cysts and then you can have one of the others. And that has evolved. Sadly, I was asked to give a talk in August to the Infertility Society, and I was giving my talk online, so I just hooked on like you guys did a few minutes before I started talking. And so I got the tail end of one of the other doctors presenting what happened at a congress where they just reviewed the diagnosis and criteria for PCOS. And sadly, androstenedione has been taken away as a diagnosis of hyperandrogenism. So I think they shot themselves in the foot, because I remember when I first qualified, I remember asking my prof to say, listen, when we test some of these patients with their testosterone and free testosterone index, it's normal. How come these people are hirsute? And then I started looking into, and for those of you who know me, I've gone into DHA years ago, and then I started looking at androstenedione in a lot of these patients, and it was high. And I can tell you, it was only years later when I went to Boston for an update, one of the guys presented, and they said they presented a small study saying they think androstenedione can be one of the main androgens for the stuff. And now, of course, they've taken it off again. So guys, if you have patients with hyperandrogenism, if the testosterone levels are normal, if the DHA levels are not high, look at androstenedione. It can be any one of those three that can cause our clients to have hair thinning on the scalp or a receding hairline. You can cause hair growth in the upper lip, in the chin area, a nipple area, on the chest, and then just between the umbilicus and the pubic area. And generally, they tend to be more hairy elsewhere as well. These patients will have acne, oily skin, more blackheads. Anyway, it's a nightmare for some of our female clients. So what are the consequences of insulin resistance if we leave it? Well, infertility. That's where this whole story started with the Stein-Liebenthal syndrome, where they found some females were having difficulty in conceiving, and then they found on ultrasound that they had cysts. And so, of course, when our clients start making follicles in the beginning of the month, you'll have a few follicles on each ovary coming through, and then at a certain point, once you get to around the 8 to 12 millimeter mark, what happens is the dominant follicle will produce something called inhibin, and it inhibits the progression of all the other follicles. And so then the dominant one will continue, and once it gets to around 18 to 22 millimeters, it's then potentially ripe, and then it will pop, release the egg, and get into the fallopian tube, and then of course one can end up having a child if the sperm meets the egg at the right time in the right space. So when you have multiple cysts all stuck between 8 and 10 millimeters, they all producing inhibin and preventing the next guy from maturing. Now typically nature, in its beautiful plan, and it's a marvelous plan, made sure that these follicles surrounding them have a layer of cells called the theca cells, and they produce androgens. And any of you guys want to hazard why that would be the case? So what happens is, close on to ovulation, the theca cells are going to make androgens, and then of course the female is going to show interest in the opposite sex and is more likely to mate. The problem is that great plan went down when you had 20 of these follicles all stuck, all making androgens, and now you got too much androgen. And that's the basis of the hyperandrogenism. There's a lot of genetic work showing that some of these people with polycystic ovarian syndrome have a genetic predisposition, and they also have a genetic predisposition to making more androgens from the stimulus of LH. So the other consequence is obesity. My belief is that most patients are insulin resistant and then become obese, rather than they're obese and then they become insulin resistant. So the vicious cycle starts the other way. We spoke about hirsutism. So depending on how sensitive your client's receptors are, you find some people will grow more hair here, some more on the back, some everywhere, and some will lose just receding hair here, some will lose it all over. That just basically is based on where the receptors are concentrated for the androgens. You can also have androgenic acne. I divide acne 4 ways. One is the one that is seen after the matric or during the matric exams. So that's stress related, high cortisol, and drives acne. The one that is related to detoxing, I'm putting it in inverted commas, or doing something to the gut microbiome. So that's the person who went to the Rustenburg hydro for detoxing for 2 weeks, and they were relaxed, eating healthy food, and a week later when they come back, their skin has erupted. That's detoxification. But the two medical ones that you and I see, one is driven by estrogen dominance, where the estrogen levels are high, progesterone levels are low. They will develop zits before the cycle in the T-zone. We discussed that on the last webinar. And then the androgenic one is driven by either high DHEA levels, high testosterone, or a free testosterone index, androstenedione or dihydrotestosterone. They will also have oily skin and blackheads, as I mentioned. And then, of course, the other consequences of not doing anything about insulin resistance is, I showed you graphically, macrovascular complications start early. So treatment, lifestyle changes, very important. And because there's a genetic predisposition, they need to go on and continue with the 10,000 steps a day, watch their carb intake, lead healthy lifestyles. The oral contraceptive pill, remember this condition belongs to gynaes. The endocrinologist came in a bit later. So look at it from a gynae's mind. Person comes to you and they're not bleeding regularly. You in the 70s. What the hell are you going to do? You want to bring on the cycle. You give them the contraceptive pill and the cycle comes on. Why? Because you've artificially taken it over. But actually, there was beautiful science behind it. When you give somebody the oral contraceptive pill, provided it's the right one, what happens is you switch off the estrogen by down regulating LH and FSH. Those two hormones are what fed the ovaries to produce those follicles. So by switching their axis off, the cysts are going to disappear. If the cysts disappear, the androgens get sorted. And so then the hirsutism, the acne improves. The cycle comes right artificially because you were using a contraceptive pill. And so they thought, okay, that was the cure. Problem is, when the couple is ready to have a child and you stop the oral contraceptive pill, we're back to square one because the pill can't fix up insulin resistance. And so through time, you saw that the treatment changed and then metformin was introduced. And metformin basically works on insulin resistance. There's some work showing that it can increase ovulation. And then there's some work showing that it helps with implantation. And there's equal amount of work showing that it may not. So whether it helps from an ovulation perspective or not, jury is not out fully. Some work showing it, some work not. But remember, we don't care about that. We want to try and get rid of the insulin resistance, which we have already shown that diabetic mums, pre-diabetic mums, are going to have problematic children from a cardiovascular perspective. Clomiphene citrate. So if you go back again to the 70s, gynae is trying to get his or her client to have a child, and they're failing. So what you do is you try and take over the pituitary function by giving clomiphene citrate, and you end up getting the client to increase the LH and increase the FSH. You're going to produce follicles, bigger chance of falling pregnant. And so clomiphene citrate came into play. And again, you basically manipulating the axis. Keep in mind that an extremely high level of androgen itself messes with that axis. But no female patient wants to be walking around with acne and hirsutism and hair loss. So the anti-androgens become very important. And then there are some off-label drugs as well. So anti-androgens, there's a natural product I use made by a company called Organic Remedies. It's called Hair, Nail and Skin by Organic Remedies, and it has beta-cytosterol and neem. So beta-cytosterol is a South American herb, Sanoa, and basically it decreases the androgens. It's used in some formulations for prostate cancer issues and BPH. In that line, products like Pingium, it's extract from tomato and a few other fruits, helps as well, but they're weak for this kind of condition where the androgens are quite high. Neem is an Indian herb that also has anti-androgenic effects. And so years ago, this product has 300 milligrams of beta-cytosterol and enough neem with all the multi-minerals, and basically it helps drop the androstenedione levels. Typically, the kind of clients I get, they have extremely high levels of androgens, so I need to use more than one product. So on the right, you see the pharmacological agents, and the oral contraceptive pill works here. That's how come a 13-year-old who is not sexually active gets the pill, because the pill, by giving estrogen, you switch off the excess, and that same excess made androgens. So if that excess is switched off and the female can't make their own estrogen, they also can't make their own testosterone, and the skin looks better. Androcur is anti-androgenic drug, comes in 10 to 50 milligrams. And when it's combined with the oral contraceptive pill, typically on a high dose oral contraceptive pills, there's one called Jeanette, Diane, Minerva. They're all a combination of a pill and Androcur, or you can use it on its own. Typically, in milder cases, you only need to use Androcur just pre-follicular phase. So you're looking at it from day 4, and you use it for around 10 days. In the very severe cases, you can use it the whole month, but it is going to mess with the client's cycle. That is why it makes the cycle irregular. And so that's why historically it's been combined with the pill, because the pill artificially regulates the cycle, and then Androcur works its magic but doesn't affect the cycle. Finasteride, flutamide, these are anti-androgens. They're used for balding in males as well. They're used for prostate cancer, and they can be used off-label for cosmetic purposes in females. Spirectin, off-label use. This is a diuretic used in cardiac patients. And what they found years ago is that these male patients with cardiac failure lost their libidos, their erections, and slowly started developing gynecomastia. So somebody thought, hey, there's something here. And when you look at it, it showed that the testosterone went down, estrogen went up. That's why they developed gynecomastia. So now we use it for its side effect in females to drop the androgens. So let's move on to prediabetes then. Should we be worried? We should be very worried. So years ago, I was at a conference and the speaker said, you know, look to the right, look to the left, and 2 of you have got prediabetes. And so from that perspective, fortunately, the crowd I move around with are not big on the heavy side, but you can see that the incidence, the prevalence of type 2 diabetes has increased, obesity has increased. So whether you've got 1 in 4, 1 in 3, 1 in 5, these are still horrendous numbers. How are you going to diagnose it? So you need to decide which society you're going to align yourself with. WHO, which is a bit more relaxed. If you look at the fasting glucose, that's the tool most of us use. Fasting glucose as opposed to 2-hour glucose tolerance test. Anything above 6 but less than 7 is prediabetes. SEMSDA follows the same one between 6 and 6.9. That's the South African Endocrine Society. The ADA and the IDF, the International Diabetes Federation, they use the 5.6 to 6.9 mark. They're less forgiving. And so I don't like the glucose tolerances because I think it's not repeatable. And number 2, it's cumbersome. How do I know it's not repeatable? Years ago, we did a clinical trial for Novartis. It was a product called Teglanite Starlix, and it was to see if you can delay the onset of diabetes in somebody who was pre-diabetic. So you identified pre-diabetic people by doing a glucose tolerance test. But what we had to do was to identify an individual at high risk. That means their parents were diabetic. And then you did a glucose tolerance test and you had to repeat it 3 times. So 3 times in a month, about 10 days apart. And we screened 10 patients. And so in the 10 patients, I had 30 oral glucose tolerance tests. And in not one individual did any one of the 3 correlate. So since then, I stopped using that test. But worldwide, it's advertised. The guidelines use it. It's better than nothing. And they say it's something that could be repeatable. But that study showed me that it's not a repeatable test. And then, of course, HbA1c, and depending on which society you use, some say you can use it, some say you can't. Typically, a level between 5.7 and 6.4 prediabetes, above 6.5 is diabetes. So, prediabetes, can we prevent these clients from becoming diabetic. So one of the first studies to do so was in the UK, called the Diabetes Prevention Program. And basically, there were initially 4 components to it. One was placebo, so you did nothing. They were pre-diabetic and you just watched them. The second was given metformin. The third arm was given the TZD that I spoke about, rosiglitazone. And then the fourth was lifestyle. And they followed these people on. Somewhere in the study, they took out the TZD because it was disapproved by the FDA. It was taken off the market, so they took it out. But when they did the preliminary studies on just that sub-cohort, there was a 70% reduction to progression to type 2 diabetes. But of course, you can't use a drug that's been taken off the market. And so what the study showed, and look to the left of those slopes, the risk reduction. Over a 3-year period, lifestyle changes decrease the risk of progression to type 2 diabetes by 58%. That's fantastic. And metformin dropped it by 31%. They didn't do a combination in this study. So everybody was quick to say, oh, lifestyle is much better, much cheaper than just giving a drug to everybody. Nobody read the small print. So if you read the small print, what lifestyle meant was that these clients were given free access to a dietitian, an exercise physiologist, and they had to go to these 2 guys. And then I forget the numbers now, but over a period of a year, they had to have a minimum visit to each one of those. And on average, each person had, the one had, I think, 16 hits in a year, and the other one had 13 hits. So whether it was 13 times seeing the dietitian, 16 times seeing the exercise physiologist, or the other way around, I forget now, I'm getting old. Like my wife said, she tells our kids, our memory bank is getting full now. That showed to prevent one person from becoming diabetic cost £72,000, whereas the metformin arm cost about £16,000. So I'm not saying everybody should get metformin. I do actually. I think it should be in the water. But this shows that lifestyle works, but it's expensive. And metformin works and it's cheap, but you also can't medicalize everybody and medicate them. So this is just to show you can prevent it. This is showing it graphically in another way. So placebo was a pedestrian. That's the triangles going straight. And you can see metformin in the dark maroon and exercise going down. What's important is you can see that initially the guys are gung-ho. They're doing the exercise, watching everything. But look at the attrition rate. Even though they got free access to dietitians and exercise physiologists, that does fizzle away. And at 5 years, they're the same. And then since then, many others have repeated the study. The Finnish, the Daking, in the Far East, the US went and did it, the Indians did it, and pretty much whether they used drugs or changed the drug or used it with just exercise, you can just see on the right-hand side, pretty impressive reductions in progression to type 2 diabetes. So the guideline talks about, well, what is the criteria for testing for diabetes or pre-diabetes in asymptomatic adults? So let's concentrate on that second part, pre-diabetes in an asymptomatic adult. This is what the American doctor would read. It would say, testing should be considered in overweight or obese people, adults, and then the criteria for Asians is different to the rest. Now, if I tell you that 70% of females in South Africa are overweight or obese, and 31% of males are overweight, then that's pretty much everybody. Let's just move on. If you've got a first degree relative with diabetes, now you include a lot more than that 70% of the females. Then they identify that they say some people are at higher risk, some ethnic groups, African American. Well, that's 80% of South Africans. If you had a background history of cardiovascular disease, you had hypertension, cholesterol, women with PCOS, physical inactivity, that's everybody in this country except me. And I've also joined that now. I'm getting 2,000 steps without my exercises. Anybody who's got an insulin resistant state, somebody. So can you see that if you go through these criteria, shit, we should be screening 80% of this country, and yet we're not. And so from that perspective, you identify the clients you go into, and what the hell are you going to do with them? The guideline says you should intervene like the diabetes prevention program and aim for 7% weight loss. You should get them to do at least 150 minutes of activity a week. You should consider giving metformin. And also consider that if you're giving somebody metformin, that you may induce vitamin B12 deficiency. So that will have to be supplemented. So what happened was, years ago, I was approached, and then I did the dossier for applying for the use of metformin in South Africa for prediabetes. And it took us the better part of 7 or 8 years. And finally, Merck got it registered. And I remember the first meeting, ed board meeting we had with endocrinologists and a few high-profile diabetologists at the airport. And I can tell you, I was grilled. I was grilled by my colleagues about even considering giving metformin in patients with type 2 diabetes. And my ass was saved by the 2 overseas speakers that were also invited on the ed board. And the 3 of us then ended up having a stronger voice. And finally, we managed to get that registered in South Africa. So the reason why all of this is important is because we all in the game of preventing diabetes, and we should be. And whatever it takes, we need to reduce the number of people who are insulin resistant, reduce the number of people with PCOS, reduce the number of prediabetes, because look at this slide. We're already overburdened with diabetes. That's the final consequence. And so look to the top right-hand corner. It says 2019, 463 million people worldwide got type 2 diabetes. And they were expecting at the time, and this was a 2019 slide, that by 2030, there's going to be 578 million. Hello, we've reached that number already. And so whatever projection any statistician has ever put out on diabetes, it has always reached way before they meant for that number to be reached. So if you look on the bottom left, that's Africa. We're expecting a massive increase in the number of people with type 2 diabetes. So, and the problem is 3 out of every 5 people already living with diabetes is undiagnosed. And 3 in 4 deaths are due to diabetes. 3 to 4 deaths under the age of 60 are due to diabetes. So let's re-look at type 2 diabetes a bit. So DeFronzo highlighted the need to address 8 core defects in diabetes. They used to call it the ominous octet. Go to the right now. That red or maroon block now looks at 11 different pathways that can lead and converge to beta cell dysfunction and type 2 diabetes. And so everybody is now recommending on the bottom left in the lime green that try and achieve glycemic goals by using drugs that have complementary mechanism of action. There's no point in using one drug that attacks one aspect of these 11 things. That's what they're trying to say. Always use a drug that has a beneficial weight profile. Don't use drugs that are going to cause weight unless you have to. And then use drugs that are going to prevent micro and macrovascular complications. And so on the bottom right, optimal therapeutic strategies should use an individualized program. So we've got to take the patient and say, here's the armamentarium of the drugs. Yes, I know what the guidelines say, but let me work out what works best for this patient. And so individualized treatment. What are our challenges? Top left hand. currently, we know of type 1, type 2 diabetes, gestational diabetes, pancreatic diabetes. Now, the problem is our definitions are imprecise and ambiguous when it comes to those three. On the top right-hand side, classic insulin-resistant associated type 2 diabetes. Quite a few of our patients with type 2 diabetes display hallmarks of type 1. Bottom left, you find obese clients with insulin resistance but present with textbook type 1 diabetes. And so there is a lack of consensus on the bottom right on whether LADA, which is late onset diabetes, is actually type 1 or is it actually early fast destruction of type 2. And so let's go through the 11 factors. So we all know about the beta cell, and we all know that these patients can start off with a lower mass and a lower functioning cell, and the end result is the insulin is defective and too little. We also know now about the incretin effect being decreased in these clients. Incretin is what GLP and GIP hormones do to the beta cells and the foregut. The third component, and this we've known from the 50s, but we've never had a drug that worked long enough to work on the alpha cell, whereas we had insulin and SUs, and so we went and targeted the beta cell. But the role of the alpha cell was always known from the 1950s, I think it's from 1956. And the alpha cell is also defective and it doesn't produce glucagon in a correct way. So insulin packages insulin, glucagon increases it. And both of them have to be in balance. And when those are not in balance, you lead to hyperglycemia. Then the concept of insulin resistance came in the 70s and recognized that there's a difference between type 1 and type 2. And the organs that were marked as the putative ones were liver, where the liver starts producing glucose when it's not supposed to. So you've got endogenous production of glucose, and it's insulin resistant. The muscles were supposed to take up the glucose, but they don't. And then the adipose tissues, a store of energy, also dysfunctional. Then the role of the brain became increasingly important, where we find that at the level of the hypothalamus, the diabetic client has already got a higher appetite than most, that they have a decreased reward system. So they need to eat a lot more before they feel like they've been rewarded. And then there's this low-grade increased sympathetic tone. And then the gut microbiome, one of my favorite topics. So it's been shown that an abnormal gut microbiome can, through many pathways, affect glycemia. Low-grade immune inflammation affects it. And now we know amylin plays an important role. And then, of course, the foregut. So the latest kid on the block about a decade ago is the kidney. And we know that the SGLT2s work there by decreasing glucose absorption. I'm just going to spend a bit of time here to make you understand and believe that this whole pathway is actually not pathological. It became pathological. If you look at every one of these factors with an open mind, you'll see how beautiful physiology is. This is 4.3 billion years of an evolutionary process starting from the earliest life form, culminating, and I don't know whether we, on top of this goddamn food chain, we're destroying this goddamn planet, but when you're looking at physiology, each one of these factors is actually trying to get you to store energy. And that's because food was always scarcity. So when we look at this and we say, wow, there's so many things that go wrong. No, these are so many things that went right over 4.3 billion years. That's what kept us alive. That's why we're on top of the food chain. Yes, we use our mental capacity. Yes, we walk. But also, physiologically, there's many protective systems here. Now, in the last 100 years, food becomes abundant. Food becomes abundant from a high dense calorie perspective, and there's lots of carbs. So the very physiology that saved our butt for the last 200 million years has now come back and bit us. And so once you start understanding all the protective mechanisms, you'll also understand how we need to change that physiology to play this game. Otherwise, we're not going to be able to fool the system. It's 4.3 billion years old. And so from that perspective, you need to understand where each one of your weapons works so you can utilize it. So we spoke about the ominous 8, and then the 3 latest ones that came in the last 5 years or 10 years is this low-grade inflammation. Very important. That's the basis of insulin resistance, actually. The gut microbiome. In fact, if I'm not mistaken, it's already probably going through registration. About a year and a half ago, they found a concoction of a mixture of the right bugs that decrease the HbA1c by 1 percentage point, which means it can be registered as an anti-diabetic agent. And then the importance of amylin, which decreases gastric emptying. Let me tell you the story a bit about amylin. I don't know if you guys know amylin. So years ago when I qualified, and it was just myself and Prof. Shires, and I looked at this molecule, we're going through basic sciences, and it's called pro-insulin. And then it gets cleaved, I'm told, to pro-insulin. And then pro-insulin gets cleaved, and then you're sitting with C-peptide and insulin. And the textbooks always said that those were waste products. And having my background in physiology from animal physiology in BSc, you realize that nothing is of waste. And I always wondered that why would the human body go through such a goddamn process just to make insulin? And so amylin is part of those waste products. And years later, they found, and it's registered in America, we just don't have it here, that when you inject amylin, you decrease microvascular complications. So in our naivety, we believe that there's a lot of things that are redundant or waste products in the system. Our maker was very stingy. Nothing is, don't ever take anything in physiology for granted. Each thing plays a role. And it took over a decade before people realized that amylin has a function. And now it's become one of the big players in diabetes. So this is going to be interesting. I gave a talk to a whole lot of dietitians, I think yesterday or the day before, at Bryanston Country Club. And so the one just before I started whispered to me that, we always get into shit for measuring fasting insulin. And so I said, and she said, can you talk about it? And I said, no, don't worry, because when the guideline changes, the international one, in a few years' time, they're going to say you can test it. So here's the proof. So go to the left, diagnostic testing and monitoring. We used to HbA1c, fasting glucose, postprandial glucose level, and then we speak about how we're going to be monitoring type 2 diabetes. Well, what's coming in the future is that we realize that type 2 diabetes is actually a cluster of 7 different pathological conditions. We just clustered them together because we were looking at high glucose as a problem. However, when we look at the physiology now, we realize that there's a lot of subtypes. And so how are we going to distinguish one from the other? Because the treatment for each one of these 7 subclasses will be different. And so you're going to be using C-peptide, islet cell antibodies. Yes, islet cell antibodies in type 2. Other inflammatory markers, you're going to measure insulin resistance with the HOMA index, fasting glucose and fasting insulin. You're going to look at measures of the remainder of the beta cell mass and markers of environmental damage and other mediating pathways and genotyping before you decide, this is the drug I'm going to be using for my patient. This guy is going to do well on GLP. That lady is going to do well on SGLT2. This person's going to need amylin and an SU or whatever. And so that's around the corner. But don't ever do fasting insulin on its own. You've got to look at the fasting glucose and the fasting insulin together, because that's the mathematical formula that speaks to insulin resistance. And the naysayers for this test was, they say, oh, but if you do it again, it will vary. Hello, measure your blood pressure 3 times tomorrow over a period of an hour and tell me if you're getting the same number. Measure your pulse over the next 15 minutes, 3 times, once every 5 minutes, and tell me if you come across the same number. Test your sugar level on the same machine 3 times in the next 10 minutes. Tell me if you come across the same number. So we've always accepted lots of our other clinical parameters and tests as being variable, and that's okay. And just because one famous diabetologist in South Africa didn't like this test because dietitians were using it, got the medical aids not to pay for it. Until today, none of us can get it done without the client paying for it. But that is coming. That is going to change. Okay. And so let's talk about treatment now. So I've been going on for 1 hour, 20 minutes. And I did say that I took on a bit more than I can finish. So traditionally, we speak for about an hour, hour and 10 minutes, and then we take on questions. So I'll tell you what I was going to do, because I am ready for it. We were looking at risk factors and then a few case studies. But what I was looking at is what each drug does from a physiological place, pros and cons, the evidence for its use, then go to the SUs, then go to the pros and cons, the TZTs, DPP4 inhibitors, the GLPs, the SGLT2s, and then give you case studies of each one showing the importance of individualizing the treatment and not trying to compete against one being better than the other. So here's the case study. So I don't know, should we take questions and answers just on insulin resistance, PCOS, and prediabetes, and we leave this for another day? But because I'm sure you guys are tired of listening to me talk for 80 minutes, can we get a bit of a consensus? The first 3 people. Should we take questions, guys? Are you guys a bit tired? So there's 55 of you. God. Okay, so we can't ask everybody, but just any opinions, put it on the chat group if you want to. What was your experience with intermittent fasting and insulin resistance? Whatever case studies, discussions would be fabulous. Yeah. So in fact, one of the doctors have actually given me 2 case studies, and I made sure I didn't look at it, and I got Leonie to put it on, because that way it's fresh. And so maybe let me stop there, because the diabetes one, I want to teach it properly, and I want us all to share and show you that although the textbooks reckon that product X will drop the HbA1c by 1%, you'll see in some people it doesn't drop it, and in others it will drop it by 3 or 5%. And so, you know, I've had people where I've reversed type 2 diabetes just by using an SGLT2, and in others it didn't bug at all. I've had a patient lose 87 kilos on the GLPs already about 8 years ago, before Ozempic came on board. And then I've had patients who've put on weight on it. And so the product doesn't change. It's the physiology that is different in the client. And that's what I want us to able to utilize in our practices. So I think, let me stop there. You can see there's still about 30 or 40 slides, and I've got about 8 case studies. So I'll refer back to the case studies now. Let's see if we can get some questions. Anybody? So let me start. Yes, let us all digest the information and case studies on another day. Should all carbs be, okay, it's such a prevalent issue, definitely worth a second session. Yeah. And so one of the things is that, will intermittent fasting help? Well, that was one of the first questions I just spotted. And yeah. And so intermittent fasting helps for 2 reasons. One is, I mean, instead of having 2 meals a day, you're having 1 or 2 meals a day. So from that perspective, you're going to be consuming less total calories. It also means that one meal less means X portion, whether it's 25, 30, 50% of that meal was carb, less carbs coming in. So from an insulin resistance perspective, you win both on a caloric perspective and on stimulating the beta cell from with the insulin resistance. And so less glucose means better for the product. But the true benefit of intermittent fasting is you start slowly and you build it up. And once you get at least 18 hours of a carb or glucose-free period, your body starts learning how to get into what we call ketosis. So the switch, the metabolic switch, happens a bit easier. Traditionally, most of us, because we're used to having so much carbs, you can take anything from 7 to 10 days to get to a state of ketosis. So you need to eat only 20 grams of carbs, and by the 7th day, your breath will smell sweet. You can test your urine, and then you got ketosis. And there are benefits to getting into ketosis, both for insulin resistance and for weight and for longevity and cancer stuff. So what I find is that if you start doing intermittent fasting, and my wife and I used to do intermittent fasting Monday to Friday for I don't know, a couple of maybe 4 or 5 years, and I just abandoned mine 2 weeks ago. And so we would do intermittent fasting Monday to Friday, and then Saturday and Sunday we'd go all out. And it's strange how quickly it's so easy to go into ketosis once your body gets used to it. So those are the benefits. And so now let me just know I talk too much. Let me just get through some of the questions. These are just CPD stuff. What about the pressure on the gallbladder from ketogenic diets? So the gallbladder, okay, no, let me take another view. Let's just go back 6,000 years ago, before we started storing grains. So it's been shown that 6,000 years ago is when mankind developed lactase as an enzyme, and that's when we were able to break the stuff. Prior to that, we couldn't metabolize that. And so long before that, most of us, and I'm a vegetarian, but most of us back then were only eating meat. You speared an animal, if you were lucky, you hit it on target, and then you would eat it. And then came fire to make it a bit easier to eat. And then taste came along. Carbs only came later in our diet from an evolutionary perspective. There were not fields and fields of rice and corn that your maker put out there for us to make bread. That's mankind. That came from engineering, farming techniques, moving from a nomadic lifestyle to a farming lifestyle. And so when a lion eats meat all day, there's no pressure on the gallbladder. And so from that perspective, we were designed mainly to be paleo. It's over a period of time we started bringing in other forms of food once we started growing it. So you would only occasionally 200,000 years ago or 10,000 years ago come across a wild berry bush or a wild pear tree. And if you go back into the literature, they don't describe fruit as being sweet. I mean, you read the Bible, they talk about sour grapes. There's no sweet grapes there. Nowadays, you can't find sour grapes. It's all genetic engineering. The amount of sugar has increased over a period of time. And so I grow produce as well. And then once you find a good fruit, you want to save that seed and you want to grow that one because it's sweeter than the rest. And so what you're doing over thousands of years, you're increasing the sugar content of some of these foods and fruits that are around. So from that perspective, the gallbladder is only a problem if you already got gallstones or sludge. Then certainly it will be a bit of a problem. And remember, fat was also difficult to find. And so the meat back then was lean. It was lean. It's only since we started keeping animals in a small area did the fat increase. That's the difference between lean and game meat and then farmed animals. So from a ketogenic perspective, the gallbladder produces stuff to help fat and fat-soluble vitamins to be absorbed. So I don't think there's too much pressure on it unless you've got an underlying problem. And the high fat in the keto diet. Yeah. And so from that perspective, I mean, we have people that have a keto diet and the cholesterol goes up, and there's people that have had a keto diet and the cholesterol goes down. That's the individuality in terms of the person's physiology. And so when you have good fats, it's easy. It's when you're having bad fats, when you're having trans and saturated fats, that's when it becomes problems. And remember, that's become an issue now in the last 100, 200 years. So there's a study years ago, even before Tim Noakes spoke about it. The Namibians invited me to their annual physicians update conference. And I think it was in the year 2000 because I just qualified as a physician. And they asked me to talk on a topic of my interest, and I spoke on obesity back then and diabetes. And I put up this GNAMI study. And these are native Canadians. And what they did was they studied these people, the third generation Canadians, and they found that the native population had a higher risk of metabolic syndrome and diabetes than the French and the French Canadian and the British Canadians. And so somebody wondered, but why? Because by third generation, everybody is assimilated. They all eating the same shit burgers. They all got a sedentary lifestyle. They all sound the same. Even the accents have changed by then. So somebody looked at it and they said, okay. And so they looked at the traditional Gnami diet. And so they took a cohort of youngsters that all had metabolic syndrome. And they took the native Canadians and fed them the traditional diet. And I put up a slide of the stuff. And it's lard, and it's walrus fat, and it's smoked fish, and molasses. That was the diet. And what they found is within 3 months of eating that every day, insulin resistance, blood pressure, cholesterol, and fasting glucose all came down in these metabolic teenagers. And so from that perspective, remember, we've got a very myopic view in terms of what's happened in the last 10, 15 years, and we say, oh, high fat in foods and all of that. Traditionally, those were all healthy fats. They were not saturated. Thank you, Doc. You have some clients before they approached me that did keto and they got their gallbladder removed. So obviously they were eating the wrong fats and precondition. Yeah. So I think what's important is the precondition. I mean, now with a lot of us using the GLPs, in terms of Victoza or Ozempic, Trulicity, what we find is that the incidence, and the surgeons will tell you, they're doing a lot more gallbladder ops than they were in the past. And so that's because the GLPs work on the foregut and they actually slow it down. It's got a response on the somatostatin receptors as well. Should all carbs be avoided, or should we be cutting out whole macronutrients, complex carbs with added protein to slow down? Very good. So this person is talking about the glycemic index. So you get high GI carbs, intermediate carbs, and low GI carbs. So all carbs are not the same. And so what we're talking about is a high glycemic carb will get into the stomach and then have a high get released, and you have a high peak of insulin, and then it's out of the system. Whereas something that has a different glycemic index will be slowly releasing. So the peaks are lower and the amplitudes wider. And so from that perspective, a classic example is apple. So apple is not high GI, but appetizer is high GI. So they'll make a newer thing or two. Otherwise, if we were meant to have grapetizer and appetizer, it would have been on the trees. But it came with fiber and it came with the skin. And that's what changes the glycemic index. And so adding protein and adding healthy fats to carbs changes the glycemic index. And I agree with this person. Protein will be better to improve the glycemic excursion than would fat. But yeah, I mean, I don't believe in extreme diets. I always tell my clients they're born with insulin resistant and they're going to have to do whatever they do till they're 84. So best they make it interesting. And I give all my patients one cheat day a week. They must do whatever they want to. They don't tell me, they don't measure their sugar levels, and their spouses are not allowed to shout them. And then the other 6 days belong to me, where they've got to eat basically low GI carbs, healthy fats, healthy proteins, and exercise. And then it's a win-win. So they're allowed to do paleo, they're allowed to do Atkins, they're allowed to do Tim Noakes, but typically it doesn't last. So the longest patient I've got with paleo is going about husband and wife from Clarksdorp, and it's about 3.5 years. He's reversed his diabetes, but that's the longest I've had. I don't see them going longer. Yes, let us digest info and then case studies later. Intermittent fasting, I've done that. Oh, can you take metformin, inositol, bioinositol, 40 ratio together with exercise and diet? Yeah. So, I mean, look, in my experience, depending on how insulin resistant you are, there's no one drug that's going to do the trick. So typically, there are patients that I've got on 2 or 3 agents. So I use a product by Organic Remedies called Glucose Stabilizer, and it's got chromium, it's got cinnamon, it's got HCA, it's got more D-chiroinositol than Inofolic and all the other products that have come by. It's got 6 items. Basically, it's got everything besides berberine. That came a bit later. So it's got all 6 items that are potent. And if you had to buy each product individually, you'd be taking 18 capsules or tablets a day. And I did the maths a few years ago, about 10 years ago. The product would have cost about 1,200 Rand, and this product's about 300 Rand. And it gives you, you need to take 2 to 4 a day, and you basically get all 6 items at maximum doses. So, yeah, and so if you wanted to use more than one product, fine. That would be absolutely okay. You just need to understand drug interactions between some of them. So metformin with inositol, 100%. I do it all the time. You can send your clients to me, exercise physiologist. Hey guys, there we go. The fitness hybrid. You've got an offer there. Please refer your clients. And remember, you know, you and I can't make it fun. So sometimes these fitness people can make it fun. I mean, sometimes it's a slog. I mean, the boxer who comes to my kids do boxing twice a week, and shit, he's a killer. You've got to have an appetite for that. So you've got to find the right person. And I'm sure our guest from Fitness Hybrid will help some of your clients. I think you're welcome to put some of your details on board, and let's see if Leonie can distribute it for you. Can you briefly recap from the last talk the ratio in the blood test of testosterone to estrogen levels? Oh no, sorry, estrogen and progesterone. Okay, so for those of you who were there, we were looking at estrogen and progesterone. They partner hormones. Forget the picomoles and the nanomoles. Just leave the units out. As Lancet gives you the result, or Empath gives you the result, in the first 14 days of your cycle, the ratio between estrogen and progesterone, the easiest one I can tell you to remember is 1 in 20. So in other words, if the progesterone if the estrogen is 100, the progesterone needs to be at about 10. 5 in the first half of the cycle. In the second half of the cycle, the ratio is 1 to 10. So in the second half of the cycle, if the estrogen is 400, then the testosterone needs to be 40. So whatever the estrogen level is, basically the progesterone needs to be 1/10 to the 1/20th. Let me give you an example. If the estrogen is 200, then the progesterone needs to be between 10 and 20. If the estrogen is 600, then the progesterone needs to be between 30 and 60. I hope that helps. That's a rough estimate, and you won't go wrong with that. Where can we get organic remedy supplements? Google it. I'll tell Leonie to put it out there. So I've been using organic remedies from when I was in Melrose Arch. We've been at our new place for 12 years. The product's been out for close on to 15 years. They've got 3 products. One called hair, nail, and skin. One called glucose. And then they've got a bone product as well. Inositol, myocytol, also great for PCOS 40 ratio. Yeah. What about semaglutide? Yeah, so we use it in type 2 diabetes. It's used off label for some of the other condition. I mean, that's why we're sitting with a lot of issues at the moment in terms of supply of this product. Now, remember, semaglutide is registered for obesity overseas. The product's called Wegovy. It's probably going to be released here in the next 6 months or so, but it's been delayed because I mean, the molecule is short, basically. And so I'm told that soon we're going to be having a factory in South Africa. So we look forward to that becoming a bit more easily available. Oh, Michaela, chromium 200 TDS. We're going to cause pancreatic cancer. Definitely no, no, no. So you don't want to be using more than 200 to 400. Once you get between 600 and 800, that's why it was banned 20 years ago in the UK. What about berberine? Yeah, so I had it on that list. Berberine also a herb that helps with insulin resistance. What does that include complex carbs? Yeah, complex. So look, all carbs will stimulate insulin. The complex ones will just do less than the uncomplex, unrefined ones. So by its nature, that's its job. Glucose was supposed to stimulate insulin release. And so, yeah, all forms of carbs will do it. Are these pathological signs, skin tags, reversible in your experience when you correct the insulin resistance? So the hump decreases, huh? The hump does decrease with insulin resistance. The acanthosis, depending on how bad it is, like this slide that I showed you, yeah, that ain't going to get better. It will just get lighter. But if you pick it up in the early stages, yeah, I mean, it does disappear. Skin tags, no, they don't disappear. All you do is you decrease the new onset skin tags. Is the presentation on PowerPoint slideshow? Yeah. Yeah, if you guys want it, then ask Leonie for it. Am I missing anything else? Any other questions, guys? All right. So I think let's leave the case studies next with, I think I did take on a bit too much. Once I was preparing the slides this morning and I sent them to Leonie to add on those case studies, I realized there's no way we're going to be able to do so much. And of course, there's then information overload. So, also the way you cook your food, boiled sweet potatoes has a lower, So look, high GI, low GI, intermediate GI, how you prepare your foods is a science on its own. And so cooked oats versus non-cooked oats, pap, cold versus warm, changes the glycemic index. It's a science completely on its own. And so that maybe one day we get the dietitians, the clever ones, to come out and talk to you about it. And so how these foods are prepared is very important. What are the blood tests for testing increased androgens? It's called, Dr. Sidat, it's called DHEAS, total testosterone, and then androstenedione. Now, there's one more, dihydrotestosterone, and it's very expensive. And so it's about 3,000 rands, and it takes about 4 to 6 weeks to come. So it's useless because by then you've moved on. And so a nice surrogate test, I found that whenever the androstenedione was up, the dihydrotestosterone was up as well. So I just used that and that is a good marker. Where can we email you, Doc? Oh, there we go. She's put it up. So my email, Leonie, can you put it up? So it's S for sugar, Bana, BHANA, at netactive.co.za. But if you send it to Leonie, she is like a pit bull. I'll get it the next morning as a printout on my desk. That will be your sure way. And then I've put out my cell phone in the past, and a lot of you have been sending me cases and for some advice. And the ones who have will tell you that I will respond within 24 to 36 hours. If it's urgent, I'll do it straight away. But otherwise, yeah, you can put up the patient's details, and then I'm happy to give you guys advice. And if it's going to be too long, I will call you. If the answer is going to be too long, because I'm not the fastest of these typers. And takes a long time for results. Yeah, okay. All right, guys. So I hope this has been okay for you guys. And apologies for that. Let's do the diabetes. So diabetes is very important. And whether you're a nutritionist, whether you're a homeopath, whether you're a GP, whether you're a specialist, whether you're a gastroenterologist, everybody needs to know how to manage diabetes, because there's no way 60 endocrinologists are going to be able to manage with all these diabetics in the country. And so it's become so interesting. There's so many different drugs, and once you know how to use them, your practice is going to become a lot more interesting. So let's leave that. And then for each drug, I've got a case study showing you how what was done before by another practitioner. And even though they had good HbA1c, once we change a regimen, the patient loses 12 kilos or 10 kilos, or the cardiovascular risk improves, or the CRP goes down. So there's always room for improvement. So I hope this has worked out for everybody. So I take leave, and I think we've covered all the questions. Leonie, do you just want to check on that and see if I've covered all the questions, or is there still something else left?
Thank you, Doctor. Thank you, Dr. Barnett. It's perfect.
All right, thanks, guys. Thanks for your time, and stay well till the next one.